So I'm thrilled to have the opportunity to talk about engagement. Not that excited to go after the lovely graphics you had there. It's going to make my slides look a little boring, perhaps. Um, I'm going to talk first about engagement, what engagement means to me, and how we operationalize it. I'll tell you a little bit as well about what we've done to prepare for precision medicine and the Precision Medicine Initiative. I know there's a lot of interest in what we're doing at Vanderbilt regarding the new PMI pilot program, and for Grace and others who've already asked, we have not accrued anyone yet. It was just announced last week, so keep that in mind. And then I'll also share a little bit about retention and what I think are important strategies around retention. So first, this is sort of the framing, or perhaps not quite a conceptual model of engagement, but it really represents what we believe is engagement across a spectrum. So when you talk about engagement, I think the most important thing to remember is that it's bidirectional. So there has to be some element of co-learning that exists. It's not unidirectional. Engagement is not the new word for outreach, which some people think engagement sounds better, but if you're only going one way, it's still outreach. You're not engaging. So what you see in this diagram is, first of all, you see a number of different approaches to engagement. And a common question that I get is, what is, which is the best strategy for engagement? And I remind people that it depends on what you want to know and what kind of input you need. In most projects, you need to engage people at many different levels. So one step in this diagram is not better than the other. It depends on the kind of input you're looking to get. So at the bottom of the diagram there, you see knowledge users. And so that's where we would see people who can engage in giving you short one-time input that you intend to use to impact the design, the implementation. This is different from a research participant, but you can still get input broadly from a large group of people. And this is important because as we're thinking about something as big as the Precision Medicine Initiative, having a small group of people who are providing you advice is not going to be sufficient. You have to have input from a broader number of people if you really want to have a design, a program that is relevant to a bigger audience. When you look at the top there, you see people who are what we would call principal investigators. And so traditionally in community-based participatory research, the community has an equal role, so they're equal partners. And I think this will be perhaps a challenge as we start talking about participant-powered and participant empowerment in the Precision Medicine Initiative, because I'm not sure that we're talking about the same as we would be doing in a community-based participatory research model. But these are people who are not just at the table, but they're making decisions. They have a substantive role in the program. One thing that I would point out as well from this diagram is that there's a dividing line there that I think is important when you're considering who to bring to the table. So the top three there, the co-PI, PI, participants on the research team, and those who are on these ongoing advisory groups, those folks typically need to have some level of experience in sitting at a table. So they don't have to have research experience. They don't have to have a particular level of education, but they have to be comfortable enough at the table and have had some leadership experience in order to engage at that level. So this is operationalized what we've done in engagement in one single project. So in our Mid-South Clinical Data Research Network, which is PCORI funded, we have engaged individuals at all of those levels. So not just one, all of them. And I think when I proposed this initially, that we would have more than 5,000 people giving input and that we would be expected to respond to it, people frowned, they cringed, they thought I was crazy. They probably still think I'm crazy, but we did it, and I think we'll have, we've built a system, a network that's going to be much more likely to engage and involve people long term. So this is, I think, really important for retention as well. So if you haven't thought about retention when you're designing the program, there's very little chance that you'll meet your retention goals at the end. So it's important to start planning your retention early on. So just in general, broad and key things that we would say about engaging stakeholders are probably things that many of you know already, so involve early. You can't just have one person who's outside the research team at the table and say you have engagement. You need to be deliberate, and I think often we talk about having advisory groups or advisory boards. That's the most common way we engage people in research, but it's probably the worst used. So we bring people to the table and then we basically give reports, and we don't give them opportunity to react or give advice, or when they give us advice, we don't actually tell them what we did with the advice. We don't respond to them in a meaningful way. So I think that there's a lot of opportunity around engagement there, but we have to be more deliberate in our approach. And I already mentioned the co-learning. So as we were preparing last year for what we thought would be more of a focus on precision medicine, we thought it might be important to really understand what our patients, what our community thinks or knows about precision medicine and how important it is. So what you see here are the results of a survey that was distributed through the Vanderbilt patient portal. So you can see from the demographics that it's probably not representative of the Vanderbilt population. It is representative, though, of those who most often use the patient portal, My Health at Vanderbilt. So about 18% of this group is non-white, and most of them who are non-white are African Americans. You can see those who have a college degree is really high, college plus in college. So 60% of people here, about 2/3 of them are women. Still, though, a range of income levels, and that represents that some of them also are retired folks. So these are the questions that we asked them related to precision medicine. So we first wanted to know how familiar they were with the terms. Then we asked questions about how important some of the concepts around precision medicine were. So what you see here are minority versus non-minority, and so we certainly wouldn't say that people who are from racial and ethnic minorities are that similar, but because of the numbers we're reporting them here in this way. So those who were minorities, only 57% of them said that they were familiar with genetic testing. So think back to the slide here where 60% of them have a college degree or more. We have 57% of those who are using the patient portal. So again, I think these people are more knowledgeable perhaps, or more active in their health than some others. And may not be surprising that very few people knew anything about precision medicine, and actually slightly more, this is not statistically significant, knew more about pharmacogenomics, which I think saying pharmacogenomics is a challenge. So I found that to be surprising. The concepts, though, on the right, and the bar graphs are not equal in the chart on the right and left, but there's no difference really in the groups. But you can see that people in both groups, all the races and ethnicities, thought that the concepts behind precision medicine were important. So you want your care, they want their care to be specific. They want genes to guide the treatment. And of course, privacy and deciding who gets their records was important to 90% of the group. Also, as part of that survey, we asked questions about literacy and numeracy. So we used the Brief Health Literacy Screen, which is 3 items, and many of you around the table probably know more about this than I do, but really a subjective screen of what your health literacy is. We also used a subjective numeracy scale that had 3 questions. You can see in the bar graph there, these are African Americans and Caucasians, so different from the previous slide, which had minorities versus non-minorities. The Caucasian African Americans had similar health literacy. African Americans were a little bit lower. Numeracy, though, there was a bigger difference, and certainly numeracy in this group of well-educated people was also perhaps lower than you might imagine. The important thing I would say here is the 7 questions on the left are about willingness to participate in biomedical research at different levels. When we looked at what predicts willingness to participate in research, race, health literacy, and numeracy all predict willingness to participate in research, perhaps in the way that you would imagine the relationship to be. But numeracy was the biggest predictor in their willingness to participate in research. And I think that's going to be incredibly important as we start to move more into precision medicine and have to communicate risk, probability, and things that are not just dependent on words, but numbers. So this is the overview of the engagement for our Precision Medicine Initiative Direct Volunteers pilot. And I have the honor of leading the engagement, although I'm sure there's going to be a lot of pain that comes along with that. We've been really excited to think about how we will engage groups broadly in this process. So for those of you who are not as familiar, what we'll be doing in the Precision Medicine Initiative Direct Volunteers pilot is we'll be prototyping the website, the consent form, the data tools to collect the basic information, as well as the patient portal or the participant portal. Later in this 1 year, it's all got to happen in a year, we will also be piloting some recruitment strategies, so different strategies for recruitment and retention, as well as some more advanced data collection. What you see under the broad engagement, community engagement studios, that's a model that we've developed at Vanderbilt that allows people to come to the table and provide input on research at any stage or phase of research. We have a community advisory board, a community participant advisory board. We'll be doing user testing on all these different models, and then we'll be launching them for pilots and getting broader review. I will say that as of last week, so remember the award was announced less than a week ago now, we have already started working on this though because of the urgency of the timeline. We've identified 17 different populations that are priority populations that we want to make sure are engaged in this in some way. So we presume that there will be people who are knowledgeable about precision medicine. Some of them have family histories of genetic conditions. Others are just interested in this, who will immediately raise their hands that they want to participate in this. But then there are many other groups who have no knowledge of precision medicine, have never participated in research, or are concerned, distrusting, weary of the process in general, that we will have to have boots on the ground approaches to engaging them. Of those 17 different populations, a number of them are racial and ethnic minorities, but one group is those with limited health literacy. So we will be using some of the strategies that we've done to use in general to identify people who are low health literacy or high risk for being low health literacy. We will screen them and we'll make sure that they're at the table providing input on the content as well as the strategies, reviewing them, that they're part of the user testing as well. We have done some early prototypes of the portal and delivering data back to them. And certainly the comment that we've gotten, not just from those who are lower health literacy, is it's a lot of information. And so something that Michael said earlier that resonates with us is that we have to find a way to return value to them if we're going to retain them in this research, especially long term. So what's valuable to someone who has a genetic condition in their family could be having access to their electronic health records in one place that they can download with a button and take it to the specialist that they're going to see. But that is not going to be relevant to most people, especially those who have limited health literacy. In fact, many of them may be concerned about getting all this health information that they can't understand. So thinking about how we'll help them understand that, but also how we will provide something that is of value to them so that they will remain engaged in the work will be important. So this is an example also of one of the strategies that we've used in a particular study that involves genetics, genomics, and retention. So the only thing that I'll point out here is that in the engaging populations of interest has to be tailored to some way. And so again, when we're thinking about this large group of 1 million people, we have to have many strategies for engaging individuals. But around the retention piece, it's about relationship building. It's about trust building. And for some of these populations, especially those who have been marginalized and disenfranchised from the research community, building trust, recognizing that there are reasons that people remain distrustful of research will require a lot of time and additional resources to make sure that we have some specific strategies to address them. Nonetheless, we are thrilled to have the opportunity to participate and think about engagement broadly, and would welcome input, help along the way. Thanks.